Thank you. Good afternoon, all the dentists joined here. Today's topic, I think you already know that topic title is Periodontics in Everyday Dental Practice, Practical Insights. Yes, let us not become only teeth dentists who look only teeth. Let us examine the oral cavity as a whole and other supporting structures of the teeth where the study involves called as periodontics. And let us all together welcome our guest speaker today, Dr. Avinash sir, uh, who is a renowned expert in the field of periodontics, who is here to elevate our session today with his expertise. We welcome you, sir.
Thank you, Dr. Bharati. Can I start sharing this slide?
No, sir, I want to give brief introduction about you.
Yes. Oh, no problem. Yeah.
Yes, sir. Let me introduce our guest speaker, Avinash sir, to you all today. Sir is a periodontist with over 18 years of teaching, research, and clinical experience. He is currently serving as a faculty in the Department of Periodontics at Jesus Dental College and Hospital, Mysore. Also manages his private practice at Sir's Clinic Dental Planet, Mysore, where he provides comprehensive periodontal and general dental care. He is a passionate teacher and researcher and has published over 30 scientific papers in national and international journals. His work bridges clinical practicality with evidence based science, making complex periodontal concepts accessible and relevant to daily dental practice. That's helpful, sir, for us. We welcome you again, sir.
Thank you. Thank you so much, Dr. Bharati. I'll just share my slide. Just let me know if it is visible once I share it.
Sure, sir.
I hope the slide is visible.
Yes, sir, it's visible.
Fine. Okay. Good afternoon, everyone. I'm Dr. Avinash, as Dr. Bharati mentioned. First of all, I would like to appreciate Oral D for organizing these kind of webinars that can help the dentists, like the general practitioners mainly, to enhance their skills as well as knowledge about uh, various topics which is very much required for day-to-day practice. Okay, so
Thank
today
you, sir.
my focus is on the key periodontal considerations that every general dental practitioner should keep in mind while doing their routine practice. Okay. I know all of you, I assume that most of them are general practitioners. So my presentation will be mainly for general practitioners. Okay. So since as general practitioners, you all maintain variety of cases, I'll be connecting periodontics with the disciplines you deal with daily, like perioendo, perioprosto or restorative, perioortho or perio implant or even perio aesthetics. So we'll be linking all these to the Perio concepts which you need to be aware of. So before we start that, before we go into the actual subject, let's understand a little bit basics about Perio. So Perio is just like, it's just a 2 millimeter tissue which is present. That's what uh, many of them say in the UG level. Like when we do undergraduation, they say it's a soft tissue, a very small tissue. Okay, but this small tissue of just 2 millimeter or 3 millimeter plays a very important role in the overall dental condition. So basically, what you need to know is the few parts which you already are aware. Just let's brush up these few parts of the gingiva: marginal gingiva, attached gingiva, and the mucogingival line. These are the things which you need to keep in mind whenever you're doing any of the dental procedures, when you think of the perio considerations. So mainly, this marginal gingiva and attached gingiva collectively are called as keratinized tissue or keratinized gingiva. So later on in my presentation, I'll be talking a lot about keratinized tissues. So we'll come back to that one later on. Okay. Now moving further, let's again, before going to the actual topic, few points about clinical diagnosis of periodontal disease. So you know how to record pockets, recession, clinical attachment loss, and radiographic evaluation of the periodontal disease. So let me touch upon that one, the correct techniques of doing it. So once you diagnose it correctly, only then you'll be able to plan the treatment or devise the treatment and decide what to do. So if your planning, your diagnosis is not correct, then the planning goes wrong and the treatment may be either incomplete or incorrect treatment. So let's see how to detect pocket. Again, you all have studied this one in your undergraduate level, but let me refine this one a little bit and tell you how to record the pocket correctly. So as we see in this picture, the probe, the tine of the probe should be parallel to the long axis of the tooth. Only then you'll be able to detect the pocket. So and also measure all the surfaces. It's not just only on only the interdental areas. You need to record the pocket on all the surfaces. Only then you'll be able to detect whether there is pocket present or not. Further recession. See, when you're recording recession or when you're looking at recession, what you need to say is whether there is adequate attached gingiva or adequate keratinized gingiva present beyond the recession. So that will help us to determine the prognosis later on. See, in the first picture, that is on the left side, you see there is no attached gingiva at all. Whereas on the right side, there is some amount of attached gingiva. So when we are thinking of prognosis, the one which has little bit of attached gingiva will have better prognosis. Further, moving on to clinical attachment level, this is very important to determine the prognosis of any periodontal disease. See, if there might be pocket, there might be recession, but what we look at is how much of attached gingiva is present. See here, how to measure this attached gingiva. I'm sorry. It is how much of attachment is present. So how much of attachment has been lost. That is what we need to see. So how to measure this clinical attachment level? So it is from the clinical cement enamel junction to the base of the pocket. So that will tell us how much of attachment loss has happened. The more the attachment loss, the poorer the prognosis. Okay. So if there is pocket as well as recession, you add up both. Recession plus pocket depth becomes your total attachment loss. So more the clinical attachment loss, the poorer the prognosis. Then, of course, you need to do radiographic assessment as well. So here we see the percentage of bone loss. Okay, so you need to measure the root length and how much of bone support is still present. So that is what we need to look at for the prognosis of the tooth. At least 50% of bone should be present for us to say the prognosis is at least fair. So beyond 50%, then the prognosis becomes questionable, or you may say even it is poor. Now, what are the factors which we need to look at to determine the prognosis of periodontal disease? One is remaining bone support, then how much of attachment loss, because pocket depth, whether there is furcation involvement or not, then other anatomic factors, that is furcation involvement, then look at the mobility of the teeth, and patient factors like their habits, how well are they maintaining their oral hygiene, smoking, their systemic health, like diabetes, uncontrolled diabetes, all those contribute to the prognosis of the periodontal condition. Also, look at the restorability, whether the tooth has caries, root caries, whether we can place the crown. All these factors become important along with the adequacy of the keratinized tissue. Now, as I mentioned, I'll be relating all these day-to-day practices with the perio considerations. So, for example, in perio endo, so I'll be talking about what all what all periodontal consideration you need to look at whenever you're doing any endo treatment or whenever endoperio lesions are involved. So to start with, let's classify or let's understand why endoperio lesion is important. See, your periodontium surrounds the tooth, and there might be some communication between the endodontic that is the pulp as well as the periodontium. So one is through the apex, as we see here. One is through the apex. Whenever you have any um, endodontic lesion, periapical involvement, it can progress to the periodontium, that is periodontal ligament region, and then cause periodontitis. Or there might be accessory canals near the furcation or elsewhere, which can where this communication between the pulpal lesion and the periodontal lesion. So based on this, we uh, classify it in a simple way. So I'm not talking about more of academics. Just for day-to-day practice, we can classify this as primary endo, secondary perio. That means it is primarily a endodontic lesion. That means there is caries or there is a tooth which has any trauma and it has become non-vital. And you have periapical lesion. And from there, it progresses to the periodontal region. So this is primary endo and secondary perio. Then we have primary perio and secondary endo. In these conditions, you don't see any carious tooth or there is no any restoration is not there. It's primarily a perio lesion. That means there is attachment loss, pocket is there. The pocket is extending up to the apex and then the tooth becomes non-vital. Or even the infection can enter through these accessory canals and make the pulp non-vital. This is also one pathway of spread of the infection. So in this case, you see only perio findings, that is pockets or attachment loss, but the tooth has become non-vital. And finally, we have combined lesion. So there is both perio as well as endo, and these two at one point of some point of time it joins. I'll just take a break. Dr. Bharati, is there a yellow line? Is something which is seen on the screen, which can it be erased? Is there anything which is on the screen, or I just wanted to confirm whether it is only seen by me?
I think I cannot remove that, sir. I won't be able
Uh,
to
is
do
it
that.
okay? Okay, so I'll just see you.
Yes, sir.
Yeah, fine. Now it's fine. Yeah, thank you. Okay, so now we know different types of endoperio lesions. So how to treat this one? Periodontally. Okay, so before we go to the treatment, what do you think this is? Like, is it a primary perio, secondary endo, or is this a combined lesion? So if some of you can put it in the chat box, what do you think it is? Whether it's primary perio or primary endo, or is it combined lesion?
I request Dr. Drishya to not to use the cursor. It is creating markings here. Please see that, Dr. Drishya. And I request participants to put up your answers in the chat.
Okay. Anyways, this one is a combined lesion because you see there is a restoration which is close to the pulp, and also on the distal aspect you see there is bone loss. So this is resulting, I mean, this has joined together. Now we call it as combined lesion. Dr. Bharati, I'm unable to move the slides. Is there any way it can be controlled by you?
Yes, sir. Sir, I will be making you as a host, sir. so
Yes,
that
please. Yeah.
others
Yeah,
cannot.
I think it's moving now. So that's fine.
Yes, sir. Okay.
Okay, so what we need to consider before planning the treatment. First, assess the bone levels, bone support available. See, previously I did mention that at least 50% of bone support should be present. So as we see here in this case, there is bone in the furcation area, there is bone. There's some amount of bone loss, but still it is adequate. And mesial aspect, there is bone present. Only on the distal aspect, the bone is deficient. So what do we do in such cases? In such cases, we can plan for hemisection of the root. Okay, so if the prognosis is poor, then you go ahead and extract. So how to determine whether the prognosis is poor or not? So first, you need to see the bone support. Overall, if the bone support is less than 50%, then the prognosis would be definitely poor. You would extract the tooth. In case if you plan to retain the tooth, then you have to follow these phases correctly. First, we need to do phase 1 therapy. That includes the initial scaling and the prophylaxis has to be done. And then whichever kind of endoperioral lesion it is, whether it is primary perio, primary endo, secondary perio, or combined lesion, always do endodontic treatment first. Even if there is some delayed response and it is close to the periodontal lesion, it's very close to uh, the periapical region, even then I would recommend do the endodontic treatment first. Wait for the endodontic lesion to heal, that is periapical area to heal, and then reevaluate, and if required, do the periodontal surgical treatment. So this is the protocol to be followed. It's not that it is because it is primary perio and secondary endo, you do perio surgery first and then do the endodontic treatment. Always start with endodontic treatment, then wait for the periodontal lesion to heal. Many a times after doing endodontic treatment, the periodontal lesion heals on its own because you're removing the source of the infection. And in case, if at all, if you have to do periodontal procedure, you can perform flap surgery with or without regeneration, that is bone graft and GTM membrane. Or in this case, the one radiograph which I showed, you can do root resection or hemisection depending on how much of bone loss has happened for that particular tooth and depending on the furcation involvement. So this is the same case which we had treated. This was done in my department in JSS Dental College. So here we decided to do endodontic treatment and then do hemisection. We have removed a portion of the tooth and finally we restored it with a crown. See, a crown has been placed and the function was restored. So at the end of each section, I'll be mentioning few takeaway points. For endoperio lesions, what you need to look at is first determine the prognosis and then decide whether treatment is actually required or not. And then if at all, if you feel the tooth can be saved, then always perform endodontic treatment first. This is the takeaway point for this section. Moving on further, perio restorative or perio prosthetic procedures. Here, one important thing what you need to know here is biological width. I know it is a bit of theory over here, but still it's very, very critical for the long-term success of the restorations what you do, which is close to the periodontium, and the crown bridges, whatever you do, you will be placing very close to the gingiva. So you need to be aware of biological width. So what is this biological width? It is collective length or collective width of junctional epithelium and connective tissue, which is nothing but your attachment apparatus. Okay. So otherwise you can tell the distance from the crest of the alveolar bone to the base of the sulcus. So this is biological width. So on an average, this biological width is about 2 millimeter. Okay. So how to make sure that you are not encroaching this biological width? Okay. So whenever you place any crown or even subgingival restorations when you plan to do, so make sure that the margins are margins have least impact on the gingiva or the periodontium, or that is the biological width. So always try to keep supragingival margin. Like let's say you're preparing a crown. So if it is not in the aesthetic region, try to keep at equigingival or supragingival so that it doesn't encroach the periodontium. But in anterior aesthetic region, you may not be able to do that. So in such cases, what precautions you need to take, I'll be discussing in further slides. So as we see here in this slide, supragingival margin has least impact on periodontium, whereas equigingival has some impact compared to supragingival margin. But if you have to do it subgingivally, then it has a greater risk of involving or encroaching the biological width. See, as you see here, later on, what happens if at all if you encroach the biological width? So it will further lead to recession. It may lead to recession later on, maybe after 2-3 years, there may be recession, or there might be pocket formation, and then periodontal disease will progress. So what we need to do, what is the criteria, or when to decide we need some procedure like crown lengthening or gingivectomy to be done. If the sulcus depth is 1.5 millimeter or less, then place the restoration margin 0.5 millimeter below the marginal gingiva. So I'm talking talking this one like in case if you have to place subgingival margin. If the sulcus depth is more than 1.5 millimeter, place the margin with half the depth of the sulcus below the marginal gingiva. That means about 0.75 millimeter beneath the marginal gingiva. If the sulcus depth is more than 2 millimeter, then evaluate and see whether you need to do gingivectomy or crown lengthening, and then follow the first rule. That is 1.5 millimeter or less, then you will have to place the margin 0.5 millimeter beneath the marginal gingiva so that you don't encroach the biological width. And also use of gingival retraction cord even while preparing the tooth for crown is advisable so that the finish line would be good and you will not have any gingival or periodontal complications later on. Coming to the Pontic design, there are various Pontic designs. So some of them are not periodontal friendly. So what are the periodontal considerations we need to take? So before that, there are four types of Pontic design: sanitary, ridge cap, modified ridge lap, and ovate. Okay, so of these, sanitary and ovate Pontics are having convex surfaces, which makes them easier for the patients to clean. So periodontally, it is healthy. So wherever possible, try to keep this design either sanitary or ovate Pontics. Okay, the key clinical takeaway points here is always try to give supragingival wherever possible. And whenever you have to give subgingival margins, make sure that you don't violate the biological width. And always use gingival retraction cords even while preparation as well as while taking impression so that the process is done well. And also try to give sanitary or ovate Pontics wherever necessary. Moving on to perio-orthodontic relationship. Okay, so here I would like to ask one question. Is orthodontic treatment harmful for periodontium? So many a times we get these questions either from practitioners or even from students in the college, whether to get the orthodontic treatment done because they have seen so many cases where after ortho the periodontium is gone worse and there's mobility has increased. All those things we do come across. So is it really true? So before this slide, yes, the common belief is that after orthodontic treatment, the periodontium is damaged. Okay. Yes, orthodontic treatment involves some bone remodeling, which means there is both bone resorption and bone formation happening. but there will be a slight tilt towards more of resorption. That's why after most of the orthodontic treatment, you see some amount of crestal bone loss. Okay. Along with this one, if the patient doesn't maintain the hygiene well, or if the orthodontic forces are too high, and if it is attempted to finish very soon, if the forces are not optimal, yes, then it can cause damage to the periodontium. But when we overall consider the benefits of the orthodontic treatment, it is more beneficial for the periodontal condition than causing harm, provided you follow certain rules. Okay. See, why it is beneficial? It is because when there is properly aligned teeth, it is easy to maintain. Okay, and also there are some more advantages of orthodontic treatment. Certain vertical tooth movement can increase the or improve the bone defect, bone fill can happen. For example, if you intrude, then the crown root ratio will improve. Okay. Also, the gingival once the gingival margins become well aligned, it's easy to perform the oral hygiene. And in some cases where we have to do crown lengthening procedure, so we can use orthodontics to do the crown lengthening so that we can restore the tooth. It also, as in this condition, even the you can see the in the on the picture on the right side, sorry, left side, there is black triangle which you see. Just by doing minor orthodontic treatment, it is filled with gingiva. So what has happened here is, because of the position of the tooth, the soft tissue has followed the hard tissue. That is, it has followed the tooth, and there is fill of the gingival embrasure with the gingiva. Okay, and also we can, with the orthodontic treatment, we can create space for the implant and we can restore the tooth. Many occlusal discrepancies like deep bite, which causes trauma from occlusion, can be corrected with orthodontic treatment, which in turn will be beneficial for maintaining periodontal health. See, on the flip side, if orthodontic treatment is not done correctly, that means if forces are too much or patient doesn't maintain well, then definitely it will cause harm to the periodontium. Okay, nowadays we know that everyone wants treatment to be faster, and everything has to happen instant. So unfortunately, with conventional orthodontics, we can't do that. So why we can't do? Because it causes damage to the periodontium. So keeping this in mind, there were two brothers, one periodontist and one orthodontist. They came up with a concept called as periodontally accelerated osteogenic orthodontics, popularly known as Wilcodontics. Okay, these two brothers, they developed a procedure wherein we can do a periodontal procedure which can fasten the treatment, orthodontic treatment, and reduce the treatment duration time. So what we do here is we give corticotomy cuts interdentally. The bone is cut, like the corticotomy cuts are given, and orthodontic treatment is carried out. Instead of doing the activation every 1 month, the activation is done for every 15 days, and the treatment can get over within 6 months. So instead of taking 1.5 years, or even 2 years, the entire treatment can get over in 6 months. There's a concept called as regional axillary phenomena which happens here. Here, when we do this corticotomy cut, it not only helps in faster tooth movement, but also there will be better bone health after the treatment. Because once we do the cut, there is more of osteoblasts which are produced, and then there is more bone formation. And during this phase, even the gingival condition also improves. The only drawback of this one is it involves additional surgical procedure. And also coming to impacted tooth management. So in the starting stage of my presentation, I did mention keratinized gingiva is important. So when you are treating orthodontically impacted tooth, let's say in this slide, there are two teeth which are impacted. In case if you have to get into this position, we need to preserve this keratinized gingiva. There might be many techniques to expose this impacted tooth and get into the position. But if this keratinized gingiva is removed or it is not taken care of, then the tooth may come into the position, but later on there will be periodontal problems like recession. So let me show, there are a few procedures. See, there is one tooth here on the palate which has been exposed, and this is one of the conventional way of exposing the impacted tooth and aligning it to the position. So why periodontal consideration becomes important here? So let's take this example. This one tooth which is impacted here, and it is slightly erupting, but it is not coming to the position. Now, orthodontically, it has to be got to the position. So how is it conventionally done? If at all, if you think of conventional techniques, what generally practitioners tend to do is they do gingivectomy in this region and then put the bracket and get the tooth to the position. But by doing that one, we are losing this keratinized gingiva, and then at the end of the treatment, the tooth may be in position, but there will be recession, and in future, there might be mobility of the tooth also. Okay. So what should we do here? We should preserve this keratinized gingiva. Instead of doing gingivectomy, we do apically displaced flap. So here both the sides apically displaced flap is done, and then the orthodontic bracket is placed, and then you get it to the position. See here the tooth is coming into position, but you have very good keratinized gingiva or attached gingiva in this position. At the end of the treatment, it will be safer for the tooth to stay for much more longer periods of time. So these are the few techniques which we can do to preserve keratinized gingiva. So I'll not go into details of that one, but here what I emphasize is be aware of the importance of keratinized gingiva, and whenever you are trying to disimpact the impacted tooth and getting that tooth orthodontically into the position, keep keratinized gingiva in mind and involve a periodontist, take opinion from periodontist, and then proceed with the case. The key takeaway points in this section is, so orthodontic treatment can significantly improve the periodontal health. Okay, so and one more point here, what you need to remember is there should be at least 50% of bone support present periodontally, and the periodontal condition has to be stable before starting the orthodontic treatment. If the bone loss is more than 50%, then don't attempt any orthodontic treatment. That may lead to tooth loss. Okay, so this point is very important. 50% bone support should be present, as well as patient's maintenance has to be good and periodontal condition should be stable. That means there is no any active periodontitis present. And for in case if you are considering faster treatments, then Wilcodontics, that is periodontally accelerated osteogenic orthodontics, is an option. Always preserve keratinized gingiva whenever exposing impacted tooth. Moving on to the next concept, that is perio-implant relationship. So nowadays, everyone are placing implant. Most of them are aware of the procedure, the bone osseointegration. There's so many aspects of prosthetic aspects. Everything is considered while placing implant. But having a good soft tissue, that is having a good keratinized gingiva or keratinized tissue around the implant is equally important. If you don't have adequate keratinized gingiva around the implant, then the implant is bound to fail in few years. Okay, it is very important to have keratinized gingiva. So you might have placed implant, the osseointegration has happened very well, but the implant is failing after a few days. You see peri-implant mucositis or peri-implantitis within a span of 2-3 years. That is because lack of keratinized tissue around the implant. So if there is no keratinized tissue around the implant, either delay the implant, you do some grafting procedures, harvest keratinized gingiva from palate, do the grafting and then place the implant, or along with the implant surgery, make sure that you do additional procedure like free gingival graft or connective tissue graft to improve the keratinized tissue there. So one more important aspect of perio implant is maintenance. Implant also requires equal maintenance or protocol to maintain that area, how we maintain the tooth. So if there is no maintenance, then obviously there will be bone loss and implant would fail. So prevention of peri-implantitis or peri-implant mucositis mainly depends on maintenance. And every 3 months, at least initially when you place the implant for the first 1 or 2 years, maintenance protocol has to be every 3 months. Every 3 months, you need to recall the patient and reinforce the oral hygiene instructions and also evaluate whether patient is maintaining well or not. Toothbrushes, specialized toothbrushes for maintaining around the implants are available. You can use even super flosses or oral irrigator devices like water floss can also be used. The takeaway point here is one thing: maintenance, maintenance, and maintenance. If you don't maintain, then the implant is tend to fail. Along with that one, make sure there is adequate keratinized tissue available. Moving on to perio aesthetics, there are few procedures which can be performed to improve the aesthetics. Uh, Aesthetics is a very broad topic. I'm sure many of you would have attended many of the lectures or even workshops regarding aesthetics. Here, what I am emphasizing is mainly the pink part of the aesthetics. You would have studied a lot about other things like composites, direct composites, veneers, all those, but the pink part, that is the gingiva, is also equally important. There are procedures like aesthetic crown lengthening which can be performed, and procedures like gingival depigmentation, and also lip repositioning to reduce the gummy smile. So it is whenever it is borderline cases where you can't perform or patient is not ready to get orthodontic surgery done, then lip repositioning is also an option. Interdental papilla reconstruction, again, it was one of the perio procedure which you can consider aesthetics. There are many options. Apart from surgeries, you can even place PRF. IPRF is quite popular nowadays. You can just inject IPRF in this region so that there is fill of this interdental papilla. Also, obviously, the root coverage procedures, wherever there is exposure of root recession cases, you can perform root coverage procedures, which will not only preserve the tooth, but also it will enhance the aesthetics. So to conclude, I would like to say that each topic what we discussed today, it's vast on its own, and it could easily take an entire day for us to explore and understand this one. Okay, my goal today was simply to make you aware of the key periodontal consideration you should keep in mind while treating the patients. So every procedure what you perform has a long-term impact on the periodontium. Maybe it simple crown preparation and placing the crown or doing a restoration. It will have impact on the periodontium. Okay, so please take care of this small tissue and respect this small vital tissue. When you protect it, it will reward you with you and your patients with far more than what you expect. But if you ignore it, the periodontium can create problems not only for the patient but for you also. You may even lose the patient trust of the patient because you have not taken off the perio. You might have done very good job with the other part of the tooth, like a good crown has been prepared, but if biological width has been encroached, after few days you see pocket there and the tooth may become mobile. So please take care of this one, this particular tissue, and let us work together and practice true interdisciplinary dentistry, which where Perio plays a vital role. And let's give our best to our patients. Thank you. So I would I've just shortened the presentation so that it is simple. I tried not to complicate it, but I'll be happy to take questions and clarify whatever doubts you have.
I request participants to put up their questions or doubts in the chat box so that it will be helpful for everyone to learn together. Sir, question from my side is like in day-to-day practice, commonly what we see like gingival recession or interdental papilla loss and all. So that is the best time to call periodontist. Would you say that, sir?
Can you please repeat the question once again?
Yes, sir. In day-to-day practice, we come across this recession cases more, and people say that gap is there between two teeth. Can you put a cement there and close the gap and all? So, in such cases, that is the best time to call periodontist, sir.
Yes. See, as you mention, I mean, you did mention about placing the restoration there. See, once the interdental papilla is lost, it is very difficult to uh, reconstruct the interdental papilla. So, if it is not in the aesthetic region, we would not actually reconstruct the interdental papilla. It's better avoid constructing the papilla. But at no circumstances that area should be filled with a restorative material. It is better left alone, and you can advise interdental brushes or flosses to clean that area and make it self-cleansing, or do some uh, the tooth can be reshaped. Odontoplasty can be done so that that area can be it becomes self-cleansing. That can be done, but no, at no circumstances there should be any restoration put there. And yes, loss of interdental papilla is indicating there is a progressing periodontal disease. So
Exactly.
that is the time when you have to consult a periodontist. You can examine yourself and determine how much of attachment loss has happened. Take a radiograph and then you can consult a periodontist if required.
Okay, okay. Thank you, sir. Thank you so much. We will take up the questions, sir.
Yes. Okay,
Somebody is
I see one
asking
question
us.
here.
Yeah,
How to
yes, sir.
manage
Yes, sir.
isolated lower recession in TFO cases.
Yeah.
Okay. So whenever there is any TFO, first thing is to correct TFO. So if at all, if you attempt any recession therapy with active TFO, then it is bound to fail. It will definitely fail. Initial few months, there might be good root coverage happening, but later on, it will definitely fail. So correct the TFO first. It may be by orthodontic treatment or any other means, like even prosthodontically, it can be corrected by placing the crowns or increasing the vertical height posteriorly. You can correct the um, anterior TFO can be corrected. Only after that, recession coverage or root coverage has to be attempted. Okay, that I hope that answers the question.
How to decide when to go for flap surgery, sir? That another question is.
See the pocket depth. When the pocket depth is more than 5 millimeter, that is when we decide whether flap surgery is required or not. But before deciding whether flap surgery is required or not, see any pocket measuring more than 5 millimeter or more, the pocket depth may reduce after you do phase 1 therapy, that is scaling and root planing. That is the mandatory procedure which has to be done for all the pocket cases. So after doing the surgery, if the pocket depth reduces, let's say now it has become 4 millimeter, then you don't have to go for surgery. But if the pocket is still persisting, even after 4 weeks or 6 weeks, that is when you decide to do flap surgery. Also, in the radiograph, if you see vertical defects, angular bone defects, whether the pocket depth is 5 millimeter or more, you definitely have to do flap surgery. It's only in the horizontal bone loss cases wherein the pocket depth is less than 5 millimeter, you don't do flap surgery.
Okay. Thank you, sir. How to manage black triangle periodontically in aesthetic areas other than orthodontic treatment?
Yeah, as I mentioned, black triangle can be managed by you can do grafting, connective tissue grafting can be done, wherein we reconstruct the papilla which has been lost. Also, the newer techniques is IPRF. We have tried IPRF in some of the cases, so it has helped to some extent if the loss is minimal. Otherwise, grafting, there are many grafting techniques, connective tissue grafting techniques, which can help in filling the black triangles. I'm
In
talking
some
from
cases,
Perio point of view. There might be some restorative methods also using gingival ceramic or even composite, a good finished composite also can close the black triangle. But from Perio point of view, these are the procedures which can be done.
okay, periodontically, if you treat that periodontically, then that is the permanent solution, right, sir? Than the other cosmetic
Uh, yes,
means
relatively permanent solution. Again, it depends on patient's maintenance and the health, other health also that
systemic health.
impacts
Yes, yes,
health.
yes. Great, sir. Yeah, in some cases, single unit crown patient presents with isolated pocket. How to decide what's the cause of such cases? How do we know biological width has been hampered?
See, once the pocket is already formed, we don't know. Like, see, if the crown is already present, and now the patient has come after many months, the crown has been done somewhere else, and you don't know where the crown was, the margins were earlier. So then we would not be able to know whether it was impaired. But we just have to guess that probably the margins were not placed properly. That's why there is pocket present right now. Okay, so in such cases, what we have to do is we open the flap, raise the flap, and see place the crown or retain the same crown, but you do a apically displaced flap or even gingivectomy. 1 or 2 millimeter of gingivectomy can be done so that further it doesn't encroach the biological width and uh, it can be maintained. Basically, maintenance becomes important once the crown is placed. So since already there is pocket, it becomes all the more important to have a good access for maintenance. So that's how we can manage. See, one biological width is already encroached. So now we don't want it to further progress. So you treat like a pocket. Treat for the pocket and that will take care of that condition.
Thank you, sir. How to go about diagnosing isolated marginal gingiva erythema in 36-year-old female with no relevant medical history? Patient presents no burning or any symptoms except the blood red appearance.
So there's no systemic condition, no medical
No relevant medical history. It's been mentioned, sir, here.
toothpaste, or it could be even mouth breathing. If it is confined only to the anterior region, it could be mouth breathing, or it could be even candidal infection. So not all the cases will have burning sensation. If it is allergic reaction, definitely there'll be burning sensation. But since the patient doesn't have any symptoms, it could be even candidal infection. It's confined only to the marginal. Um, Otherwise, assess for the mouth breathing.
Or can it be plasma cell gingivitis, sir?
It could be, and it's mentioned only in one and 2-1 region. So you
Yeah,
can even
form
take
of
a
lichen
radiograph.
planus. Yeah.
Yeah, but it is confined only to that's what the follow-up
Only two teeth.
question is.
Yes, 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 sir. Yes, sir. Any other questions, participants? Any questions, participants?
Okay, I would like to add a point regarding when to call a periodontist. So apart from what Dr. Bharati asked, there are many times when the tooth is mobile, when it is grade 2, more than grade 2, like to say between grade 2 and grade 3 mobility is present. That is when many of them realize that they should call a periodontist. But that would be too late to call a periodontist. So what I would recommend is whenever patient comes for routine examination, try to check for the pocket, and if required, get a radiograph done, OPG done. You'll be able to see the bone loss, the overall bone loss, how much of bone loss is.
Sir, is there any network issue from your side, sir? Your video is and audio is stuck. Both are stuck.
Is
Hello,
it fine
sir.
now?
Yes, sir. Now
Is it
it's
fine now?
audible. Yes, sir.
Okay, so when to call a periodontist, that's what I was talking about. That would be too late to treat. So the recommendation is whenever patient comes for routine examination, check for the pockets along with other findings. What is like you definitely would look for caries and other findings, but also look for pocket. And pockets are best examined after scaling. Once you perform the scaling, that is when you need to check for the pocket. So then you'll be able to exactly know the pocket depth. So, and also get a radiograph done, preferably a OPG, so where we can see overall bone loss. And if the bone loss is more than 20%, then you should have a periodontist consultation for that patient, so that we can get to know whether the disease is progressing or not. So that can prevent further bone loss, and anything which can be done initially can be done, like you can plan for local rectal. First, at least it can be prevented from progressing further.
Okay. Any more questions from participant side? In some patients after ortho treatment, there is attachment loss. Somebody is asking, sir, that.
Yes, that is primarily because it is not maintained well. So we have seen so many cases wherein all the teeth would have become
Sir, it's stuck again.
stuck again. I'm sorry.
Sir, it is stuck again.
Can I rejoin once?
Yes, sir, please. I think no more questions are left, sir.
Okay.
We would like to thank you for all your insights, and few things are really very much new for us also, like Vilcodontics and all, and the reconstruction of the papilla, interdental papilla when it was lost. These were things which are completely new to us also. Thank you once again for your insightful session, sir. And I would like to
Uh,
thank all the participants also for your active participation and enthusiasm.
Thank you, Bharati. I would be happy to take questions if they have later on.
Yes,
If
sir.
they can communicate with you, I will be happy to help them out more.
That's really very kind of you, sir. Sure. We will take up, sir, if there are any.
Thank you so much.
Thank you once again, sir. Thank you all once again, all the participants. I'm ending the meeting, sir.